And with us today is Samantha Kavaliunas, LCSW, CADC, CCTP. She's the Trauma and Mood Coordinator for Timberline Knolls. In her role, Samantha facilitates trauma-informed care training, advanced trauma groups, develops and implements curriculum, and strengthens Timberline Knolls' ability to treat residents suffering from co-occurring mood and trauma diagnoses through group and individual treatment. So without further ado, I want to welcome and thank Samantha for coming here and presenting today.
Awesome. Thanks so much, Amanda. So I will be talking about what it looks like essentially to navigate through an initial kind of trauma recovery journey. I think there's so much complexity to trauma that we oftentimes, think of trauma recovery as like processing it and just like absorbing it and kind of moving on. And I think that's where we oftentimes do get kind of stuck with the individuals that we work with, because there's kind of more of a complexity to that, just as much as there was that complexity to the trauma beginning and kind of coming up. There's going to be a complexity to like how we make sure we help heal that trauma in the best way possible. And so when I am looking at, facilitating either my trauma groups or trauma trainings, I always look at this idea of transcending through our trauma. And ultimately transcending means, get to the next slide. Transcending means to overcome in a way to triumph and like overcome beyond, maybe even where we were before. So when we're looking at transcending through the trauma, we're looking at how do we heal that trauma, especially in a long standing way. It's going to take, months, time, years, things like that. But ultimately, how do we overcome it in that way of being able to kind of carry on with our everyday lives and not have such a hindrance because of the experiences we went through. So when looking at this idea of transcending through trauma, it gives us a way to have a different connection with what that trauma experience looks like, as well as what that overall recovery is going to be and kind of what it's going to mean for the individuals that we work with. Would anyone like to chime in with their kind of thoughts on what they feel like trauma is? What would they say there? If, someone said, what is trauma? What's your Webster dictionary version? Whether you add it into the chat or want to unmute. All right, so I will go in with how I kind of explain what we're looking at when we're looking at trauma recovery. So trauma is not about the specific event. So when we often think of trauma, we think of abuse, neglect, we think of kind of these big events that have taken place in someone's lives that they're, struggling to manage and kind of deal with. And that's not necessarily just the case. Ultimately, trauma is the response that we have within us because of that event. And typically that response is so distressing and disturbing that it overwhelms our natural ability to cope. It oftentimes brings a lot of helplessness. It diminishes our sense of self. So when we're looking at like who we are authentically, that no longer has that connection, our authenticity to who we are. And then we struggle with feeling a full range of emotions and experiences. So with all of these pieces connect to that one kind of trauma situation that happened, or when we think of our complex trauma, that ongoing trauma. So when we're looking at working with individuals through trauma recovery, we're looking at how do we manage that response and how do we heal that response, not heal the trauma itself. If we think about it, we're never going to be able to heal what someone's been through, right? We're never going to get an abuser to say, I'm sorry, or to say like, my bad, not going to do that again. And so if we stick to the whys with the individuals that we work with, then we're never going to ultimately give them the best space to progress forward and have that way to overcome. However, if an individual is, say, hypervigilant because of the trauma they get through, we can heal the anxieties, the stressors, that overwhelming feeling that's attached to that hypervigilance. And that's what we'll see ultimately within that trauma recovery. And we also do look at that we need to understand how the experiences affect our innermost sensations, and that there is kind of a sociological imprint left from that trauma experience within our mind, our body, and our brain. And so that's why we have books like Body Keeps the Score and What Happened to You that really do talk about how the brain is affected by trauma, how our body overall, how we feel that trauma, and how we try and make sense of the trauma. And a lot of the times that natural way just is too overwhelming. And so then we have individuals that end up in facilities or needing that extra trauma care in that outpatient level. So a lot of typical trauma related symptoms that we'll see, especially in our level of care here within residential, we see a lot of dissociations, which is essentially a disconnect from reality. So it's where our minds are kind of going elsewhere as a way to protect. Dissociations are actually our freeze response. When we think of our fight, flight, freeze, that is our freeze response coming into play. A lot of our substance use, self-injury, distorted eating patterns, all of those kind of behaviors that we see that are hindering individuals in their everyday living can have that stem from trauma responses. And that's not to say that all eating disorders, have a history of trauma or things like that. We just are noticing that if this pattern and behavior does exist, there could be this kind of underlying trauma connection existing there. So instead of just labeling anxiety as anxiety or just labeling, flashbacks as, oh, they're stressors, if we do really look at the fact that trauma happened, and so therefore these symptoms are that result, that internal mind, body, brain response to the trauma, we're going to then be able to take that step forward and help those individuals no longer have those dissociations or have less, no longer numb, and find how connections can help them, no longer focus on that shame and the guilt and the self-hatred, and really heal all those components, which then overall heal that in that trauma recovery way. And these are not the end all be all list of all symptoms. These are, again, just kind of the ones that, we'll see the most within like inpatient residential. As we're getting into that outpatient level of care, we're hopefully seeing some of these either lessened or not as frequent. But this is at least on our end within a residential, what we typically see the most. So clinically, the goal that we're trying to focus on when working with residents is that we want to understand how that trauma reaction is manifesting within that individual, and how do we explore skills and resources for that individual that increase functioning, overall repair, and heal. So we're not looking at just overnight stopping any maladaptive behaviors. We're looking at these maladaptive behaviors are no longer working. A lot of the times they at one point were adaptive. So if we think of something like dissociations, now, maybe 10 years after the trauma, we're noticing it's hindering. That individual is no longer able to, engage in everyday living because of the dissociations. But in that trauma moment, that dissociation was an adaptive behavior. It was powerful. It was important. It was their survival resource. So now that it's no longer adaptive, we need to kind of look at what behaviors can we start engaging in that are going to be those skills and resources to help rise above that trauma and heal, versus engaging in those behaviors that are hindering and no longer giving us that progression and triumph forward. And so a lot of times it can even just begin with how we label those behaviors. I personally, when I'm leading a group or talking with an individual, I try and make sure I'm not using words like right, wrong, bad, and good, because again, those behaviors weren't necessarily wrong behaviors. They're bad behaviors. They're just not working anymore. So I use maladaptive and adaptive behaviors. Our maladaptive are the ones that we would typically label as, negative and wrong. Our adaptive are going to be our positive coping skills. Our healthy ones are ones that are ultimately helping us transcend. And so how we do this, it basically starts with support. So we can't process trauma. We can't jump into things like EMDR, our trauma narratives, things like that, until we understand that like baseline and what that support is going to look like. And so again, understanding that trauma, it's not about what happened to you, but it's kind of that idea of what's going on inside of you as a result of that trauma. Since we can't change that the trauma happened, we want to heal the wounds that the trauma is leaving behind. We want to understand those manifestations within our our body and heal those manifestations. And so in our clinical role, we're going to be looking at supporting individuals by engaging in those adaptive coping mechanisms, looking at a meaningful purpose in life, all of those type of baseline foundational skills, so that way when they go into things like EMDR and processing and creating their trauma timeline and all of those things, they have that foundation of being able to internally manage all the stuff that's about to come up. And all of this begins with us providing self-regulation for the individuals. So that self-regulation piece essentially means, because of the trauma, there's an internal dysregulation taking place. So when we have individuals rate, their anxieties, their stresses, their overwhelming feelings, and they give us that range from 0 to 10, when they're giving us all those 8, 9s, and 10s, it's because they're dysregulated by those emotions going on. Even though those emotions might not be tied to their trauma directly, it still is that result of it. And so if my anxiety and my stressors are at a 9 or a 10, me trying to process my trauma isn't going to go anywhere, because I'm going to be so disconnected with the reality, with my sense of self. That's why if we ever threaten things like inpatient when someone's dysregulated, it doesn't often go anywhere, because there is no way for them to hear like a consequence to an action that they have going on. However, we can teach them how to regulate themselves. And so I'm going to go over some grounding skills as well as some DBT skills that can be utilized to help that self-regulation. So as we're learning how our individual that we're working with, what their symptoms are that they're displaying that are connected to their trauma, we can then start attaching these skills to those symptoms to heal those symptoms altogether. So if their baseline is an 8, 9, 10, that baseline will now ideally lower, maybe something 4 or 5. And at a 4 or 5, they can look at their EMDR. They can look at doing their trauma timelines, their processing, all of those type of things. And then they're going to get to a place where they're going to be at that, 0 to 3 range. When we're looking at this self-regulation and building awareness, it's not making our trauma responses and behaviors go from a 10 to a 0. It's looking at lowering them enough to make different decisions within the moment. And so we're going to be able to connect more with ourselves, see our self-worth, identify who we are, as an individual in 2023, despite the trauma we've been through, all because we've built up that self-awareness within our trauma recovery overall. And so a lot of the skills and resources that we start with the individuals that we work with is grounding. And so those grounding skills I break up into 5 areas, and there's different ways that we can use each of the 5 with the individual we're working with when they're dysregulated. And these can be dysregulations anywhere from those dissociations and flashbacks all the way to having those self-harm urges or that distorted eating behavior. So the first one I often start with is our body. So how can we use our body to ground to the present moment? How can I mindfully know I am presently here, leading this presentation? Again, it's 2023 and not maybe necessarily where my mind is trying to take me to. And so we can use our body by physically feeling the space around you. So if I have an individual that's dissociating, I will have them either sit on the floor or in a chair and feel the floor underneath them, have them push their feet into the floor, have them push their back into a wall, or if they're sitting in a chair, doing all those things within the chair, using their toes to push into the floor. If they're barefoot, if they're in their shoes, it might be like flexing and pointing their toes, or using things like squeezing Play-Doh. They can color really hard with a crayon, things like that, but to really connect their body to the moment. Another way that we can utilize grounding skills is using our 5 senses. So either all 5 at the same time if we're able to, or picking and choosing depending on our situation. So being in a residential facility that caters to individuals with eating disordered and distorted eating behaviors, we don't have access to, food the same way that like an outpatient facility would. So I'm not always able to use my sense of taste to re-regulate, but I might be able to grab a piece of gum or have to use one of my other 4 senses to kind of make up for that. But once I'm at an outpatient level of care at home and I have my purse and my backpack available, I can have everything I need for these 5 senses. So it can be things like wearing your favorite sweatshirt or something that's comfy, using things like essential oils, lotions, scented hand sanitizers, drinking cups of tea. That kind of hits a couple of senses there, because then you're able to use the heat of the tea, the taste of the tea, hold that cup in your hand, things like that. Any way that we can engage our senses. This 5, 4, 3, 2, 1 picture that I have listed up is a big one that we use here in residential so that we are able to engage all our senses. And so it can be a common one that you can utilize with the individuals that you work with as well. Then utilizing self-soothe and distract. So this is where our fidget toys come into play, which are definitely a hot commodity here at TK, or using things like taking a shower or a bath, going for a walk. Essentially, self-soothe is doing things that we enjoy to help re-regulate where we're at emotionally. Using observe can be a great one for any type of flashback or dissociation, because again, it's helping bring you back to the moment. So I'll have individuals look around the room and describe specific objects to me. I might say, tell me how many couches are in this space. All of our residents are provided a water bottle. So I might say, how many water bottles do you see in the room? Pieces like that to have that connection with where they're actually at in that moment, even if their mind is trying to take them somewhere else. And then breathing techniques. And this is probably going to be the most important of all 5, only because you can do these techniques no matter where you're at. I use the example, how many of us get dysregulated when we're at the DMV? I can't necessarily whip out my hot cup of tea, but I sure can do some breathing techniques while I'm trying to navigate being at the DMV. And so there's different breathing techniques that can be done. An important one that we use with our residents is square breathing. And so it's like the picture here, where you're just inhaling, exhaling, and holding in the shape of a square to help kind of monitor what you're doing. And typically any type of exhale that you do want to make for counts longer than the inhale. Otherwise, any type of regulated breathing will help. So those are some of the grounding skills that we like to use. And then ultimately the next step, once we're regulated enough to kind of take in the space around us, is looking at engaging in different like clinical skills. So in our case here at Timberline Knolls, our primary therapeutic technique is DBT, which is dialectic behavior therapy. And that's essentially aiming at understanding and accepting feelings, learning adaptive coping skills to manage those feelings, and making overall positive life changes. And one of the major reasons we use DBT within our facility is because trauma is essentially saying, I don't know who I am. I'm feeling very helpless and I'm disconnected from my emotions. And DBT is helping me reconnect to my emotions, figure out who I am, what's available to me, and then how do I ultimately have this kind of meaningful life for myself. And so DBT is broken up into 4 modules. With our residents, we do go over all 4 modules, and majority of the skills that are attached to each module is part of the groups that they attend. But ultimately, between not only their trauma work that they're doing, but picking up on these adaptive coping skills, together they're forming again that foundation for their self-regulation and self-awareness. 2 of the DBT skills that I want to make sure that I touch on today are going to be stop. So stop is a fairly simple one, because again, you don't need anything like with you in order to complete it. But a lot of times when someone's dysregulated, you can kind of go from 0 to 100 fairly quickly. And so stop is giving us the space to recognize like things are escalating, that dysregulation is starting to come up. So I need to stop, kind of freeze in the moment. I need to be able to take a step back, take a breather. Maybe it's completely leave the situation that's dysregulating me in the first place, or it's just taking that step back to kind of see things from a different perspective. I'm going to observe what's going on around me. So is this where maybe things that are like cognitive distortions are coming up? Maybe I'm able to observe that those maladaptive behaviors are trying to come up and whatnot. And then I'm able to proceed mindfully. So I'm able to act with more awareness. I'm able to look at my goals. I'm able to look at things like problem solving. And the decisions that I ultimately make at the end of stop are going to be very different than what I would have done within that 0 to 100 timeframe. And then another one that is great to use quickly with any type of dysregulation is coping ahead. So a lot of times, again, when we're dysregulated, we're looking at what in the world do I do, especially if an individual knows that their typical behaviors are not ones that they want to continue to engage in. Coping ahead gives us a space to understand the problem at hand, come up with more problem solving skills as opposed to that immediate reaction, and looking at what will it be like when I engage in these adaptive features, as opposed to going back to what feels comfortable and happens to also be maladaptive. So within Cope Ahead, we're able to, again, look at that problem, decide what coping skill or problem solving skill we want to use, imagine that situation, and then rehearse it. So that way we can be ready for if and when it comes up. And then ultimately practice a relaxation or a mindfulness afterwards. So that way we have the space to go through that problem solving and know that afterwards we can kind of have that breather or that moment for ourselves. So that is ultimately that foundational piece for what we're looking at within trauma recovery, to get the mind, the body, and the brain back to kind of a baseline to continue on with any work that we need to carry on with for our continued recovery within trauma.
Amazing. Thank you, Samantha. We're waiting for our moderator, Amanda, to get back on. She just got bounced out. But while we're waiting, I wondered if we could talk briefly a little bit about, in your experience, grounding exercises or groups of exercises that's been most popular with your clients. Can you talk a little bit about that?
Yeah, definitely. So like I had mentioned previously, I like to use a lot of the body ones. Unfortunately, majority of the symptoms that we see are going to be like those dissociations and those flashbacks. And so since the individual feels very disconnected from the present moment, I like to use that body and the observation to help bring back to the present state. And so I'll use certain mantras to kind of help bring that individual back. And I kind of just keep repeating it over and over again until they're re-regulated back in that moment or regulated enough to do other things. So I might tell an individual like, hey, it's me, Sam, I'm here with you. We're sitting in a group room. We're at TK and we're safe. And I'll just do that over and over again. I might add in other things like say I'm able to get a frozen orange in the meantime, which we utilize as a sensory tool with our residents. I'll give them the orange and I'll then bring that into the mantra. I'll say again, it's me, Sam, we're here at TK in a group room, we're safe. I'm putting a frozen orange in your right hand. Let's feel the sensations of that cold. And then I kind of add that in on repeat. And then once they're able to come back presently, then I have them kind of take over. They tell me what they see, what they feel, things like that, again, in that present moment to help reground and center themselves. The breathing is a great one as well that we'll utilize if there's maybe that like hyper arousal or awareness coming up where it's not that complete disconnect where they're like, no longer there mentally anymore, but maybe that sense of fear and safety is being altered. And so any type of deep breathing to kind of re-regulate, again, we're here, this is the moment we're in, we are safe, even if our mind is telling us otherwise. I'll also use a little snippet with the residents where I ultimately say, if you look around the room, is there anything that you can tell me with 100% certainty is unsafe in this space? And a lot of times they'll say, well, yeah, I could pick up this chair and throw it at you. And so I agree with that could be, something that takes place. But that certainty and that perception is taken away when you say, I could pick up that chair and throw it at you. That chair is not unsafe until we make it unsafe. And so it's kind of like looking at the world with that lens on of how do I look at it of things are not unsafe until they are unsafe. If a bear is chasing me, things are now unsafe. And I hope my fight, flight, freeze kicks in. But until that bear is chasing me, I should be at that kind of even keel baseline for myself. And so that's usually a little snippet I'll kind of throw their way to help remind them that there's a lot more perceived fear than there is actual fear, especially in our setting.
Thanks so much, Samantha. The other thing that I was wondering too is when I think about grounding techniques, it's been my experience, and I wonder if you can speak to this as well, that certain grounding techniques are, I want to say, used, liked more based on which age group that you're working with. Like the grounding techniques that like a 14-year-old might find useful are different than maybe what 35-year-old would find useful. Can you speak a little bit to that as well? Because I in our audience, I know that we have people that are working with a lot of like a pretty wide age range of clients.
Yeah, definitely. So I would say that adolescents enjoy fidget toys the most, not that our adults don't, but there's just something about how the kids love, whether it's a Pop-It or, a stress ball, whatever they're using. I even have stress balls that are unicorns, so that makes it even more fun for the residents to utilize. But ultimately, it's going to be the ones that it kind of depends almost more on the individual than necessarily just the age range. If we think of deep breathing, I have balloon breathing on my presentation because that is one I do find the kids enjoy the most. I don't know if that's just the connection because like blowing up a balloon is more fun when you're a kid or what it is. But that is one where the adults, you can more so just guide them through, like breathe in and hold and things like that. Whereas the kids need that connection to, okay, we're blowing up a balloon. And there are a lot of great mindfulness resources out there with different breathing techniques and like labels that you can have for them. There's even a book called Breathe Like a Bear. I have a 2-year-old, and so we read that one together, and it's a bunch of different breathing techniques, but it's like breathe like a snake, breathe like a bear, all of those type of things. So it's fun for the 2-year-old. And I know that she's learning how to regulate herself. So everyone wins.
Yeah, I love that book too. Okay, so what about, I'm getting a question coming in too. It's kind of two parts,
Yeah.
but similar. As you noted in your presentation, many people who are coming to treatment for trauma also have other diagnoses as well. Yeah. We see a lot of eating disorders. We certainly see a lot of substance use disorders. How do you and can you start processing the trauma if somebody is actively involved in using substances or using symptoms of their eating disorder or disordered eating?
Yeah, definitely. And so that's why the foundation within trauma recovery is that self-regulation and the self-awareness, because you definitely will not be able to appropriately do, again, EMDR processing, trauma timelines, trauma narratives, all of that type of stuff until that foundational component is there, especially if there isn't an understanding between someone's diagnosis and their trauma, because we don't have to be diagnosed with PTSD to have trauma. A lot of our trauma stressors and symptoms exist because we're humans and we have self-compassion, and that got altered and now we have trauma. And so when an individual is engaging in those maladaptive behaviors, it really is connecting to how do we heal that maladaptive behavior and then begin all the other pieces. So in our facility, because we do work with individuals with eating disorders, addictions, mood disorders, all of that, we are able to give them the space to work on their coping skills by going to certain groups. They're working on their self-image by going to those groups. They're working on their distorted eating patterns by working with a dietitian. So they're kind of honing in on all these areas, but it's all together that recovery from almost everything that's being foundationally built for that next level of care for them. So if an individual is not able to self-regulate, they're probably still engaging in those maladaptive behaviors, even though they might have kind of multiple different diagnoses happening. And a lot of those diagnoses come from a place of a lack of self-worth. And a lot of that lack of self-worth comes from the trauma, comes from the lack of self-identity, comes from that shame, the guilt, the self-blame, that all again kind of ties back to that trauma itself. And so as we're learning this plethora of adaptive skills, we're applying it to all these areas. So just because I learn about, shame and guilt, I'm able to say, here's how it applies to my grief. Here's how it applies to my trauma. Here's how it applies to my eating disorder. And all of those kind of come together in all these little moments that overall make trauma recovery.
Yeah. No, thanks for expanding on that. I think it's so important. You mentioned this as well, that like a lot of the symptoms, all of the symptoms are serving a purpose. Individuals the symptoms wouldn't be present if they weren't serving a very useful purpose. And, whether that's substance use, whether that's self-harm, whether that's binging or restricting, they're protective in many ways.
Yeah. And we'll even see that in faking those behaviors. So that's, I think, a piece that sometimes gets missed too, because we're just looking at it as attention seeking or pieces like that. And ultimately, like, yes, you may not really have like tics, diagnosed tics, things like that. However, but you are displaying tics, you are engaging in that behavior. So what is that telling us, even if it isn't like a formal diagnosis of tics? We see that a lot with our residents, or dissociating, where they're consciously dissociating, which we know clinically isn't really a thing. And so if that's something that they are claiming is taking place, it's looking at, well, why are they having this behavior come up, even though it's, again, not like a diagnosable behavior, and being able to, again, kind of treat and heal the fact that this behavior is displaying in the first place.
See another question coming in from the chat. Do individuals ever relapse from trauma recovery? And if so, how is that handled?
Yeah, I don't necessarily refer to it in relapsing in our setting. I look at it as kind of habit building, right? So there's going to be days where I wake up and I have this horrible negative self-image on myself. Maybe by noon, I'm able to start having some, healthy thoughts coming through. And that's okay, just as much as if tomorrow I had no negative self-thoughts, but had helpful ones coming in. There's going to be days that ebb and flow. If I just did have a big process, group or session, I probably am struggling a little bit more than on the days where I was, doing yoga or something like that. But that's just showing us that trauma recovery, that it's each and every moment that come together to serve the purpose for that recovery, not just the days that something successfully happened. Because even just an interaction between two peers can be just as powerful as an individual session or a group or a meeting with a psychiatrist, things like that. And so it's kind of like honoring all that. So instead of labeling it as a relapse, especially there's kind of a negative connotation with it, I just look at, we just need to keep those healthy behaviors going, those adaptive behaviors in the midst of the maladaptive ones that are still trying to sneak through.
Karen Thompson is asking, what are some common mistakes made by clinicians?
Yeah, I would say it's jumping the gun and trying to get that processing going, because again, we do see trauma recovery as getting all of the horrible things that happened in my life out. And so that kind of trauma dumping takes place. And then the individuals, pulling their hair out, banging their head at the end of that hour-long trauma dump because they don't know how to self-regulate. And it can easily be saying, this is not the time and place to, get all of your trauma out necessarily. So how can we break it down in a way to fit that self-regulation in, so that way when all of our story comes out, the key when we're looking at our trauma narrative, our trauma timeline, things like that, is connecting our story to who we are. So it's no longer me and a story, it's the two coming together. But I cannot connect to my story if I'm disconnected from myself, because I don't know my emotions, I'm feeling helpless, I don't even know my self-awareness and pieces like that. So I have to start at building that self-awareness first, building the connection to my emotions, and then can get the ball rolling when it comes to the processing and things like that. And so it might be, maybe someone wanted to process and it kind of, word vomited out, and here we are. Can we maybe do like a mindfulness activity or a grounding activity directly afterwards to show and reinforce that self-regulation?
Mm-hmm. And along those same lines, another question just immediately followed. Any best practices for working with clients who are really resistant, and doing trauma work with them?
Yeah, so trauma stems from fear and feeling unsafe. So that resistance is most likely coming from a space of feeling unsafe, of feeling fear. That fear may be change, maybe uncertainty, maybe a fear of, the unknown. And so how do we maybe look at trust and safety first? So now we're even like, we need an extra layer of foundation under our foundation kind of thing. So instead of starting with self-regulation, we have to start with that rapport building, with creating that sense of safety. And then once we have that, then there will realistically be less of a hesitance to what trauma recovery looks like.
I love both of those answers. I remember my first field placement when I was in my master's program. And I think, like a lot of therapists, I got into the field because I wanted to help people, right?
Yep.
I want to feel better. So I was always finding myself jumping to solutions and wanting to solve the problem very quickly to help them to feel better really, really quickly. And, you know, I remember my supervisor then saying, you know, you really need to like stay in like the process of exploring the problem, building that rapport, building that safety. You can't just jump to solving problems and solutions. And I think that part of the healing from the trauma is the experience of the alliance that you build with a safe other. It creates a corrective emotional experience, a corrective relationship that is healing in and of itself.
Yeah, definitely. I mean, there's a reason that like therapists get, you know, made fun of for, well, how did that make you feel? You know, like that's our tagline for a reason, because it isn't about like, well, what did you do? It's about like, how do you feel because of, you know, what you chose to do in that space, which is why we're starting to notice that that numbing isn't working anymore, that self-harming isn't working anymore. Those connections and what we are emotionally getting from that aren't what it used to be. If I self-harm every time my parents fought, it probably felt great then, but now it's, you know, 10, 15 years later and it's not feeling great anymore, but I don't know how to break that habit. So how do I recognize that it is trauma, you know, being an environment of that kind of, verbal abuse, and heal from that to therefore heal that self-harming urge.
Can you talk at all? I know a lot of, there's a lot of literature and a lot gets talked about, especially when working with trauma, around how trauma is somaticized, how people hold trauma in different parts of their bodies, and how some of the trauma work is deeply somatic and sort of doing that body work. Can you, I don't know if you can speak to that at all, but there was some interest in understanding that as well.
Yeah, I can speak a little bit on that. We also, within our facility, we do have trauma-informed yoga facilitators. So not only are they working within their trauma groups and within their individual sessions, but they're also going to yoga and doing all the things that help their body heal without even realizing it's like trauma healing. But ultimately, our body and brain gets altered because of that disconnect that took place. So that helplessness, that disconnect with our emotions physically altered our brain and our body, which is why someone that is struggling seems so tense or always has a racing heart or always has a headache and a stomach ache, things like that, because it's physically being held in them. I mean, think about when we're stressed, how like just internally we are all over the place. And that stress may be, I forgot to start the dishwasher, or that stress may be, I just got into a car accident. You know, those both cause stress in our bodies, even though they're clearly different on a scale of stressors. And so it is looking at how do we understand why that physically got held within us, right? So like one of the groups that I teach with our residents is the brain. And I talk about the neurobiology of trauma. I talk about 6 pieces of our brain, how they're supposed to function, how our trauma impacted how they function. And it's not even necessarily, we'll do this and that'll heal your hippocampus, or just do this and then your amygdala is fine. It's really understanding that like, hey, this is what your hippocampus is supposed to do. This is how trauma disrupted that or altered that. And here's how trauma recovery is going to heal that. So it gets to go back on track. And it's the same thing with anything that's kind of dysregulated within us. Our body is physically reacting to that fear and that threat around us. So we need to get it back to its baseline so that we're not always on edge. And we're also ready if fear truly does need to exist. You know, if I'm being chased by someone with a chainsaw, I really, really, really hope I run, you know, like I kind of need that to happen. So we want that for the individuals we work with. We want their fight, flight, freeze, fawn to exist because we're humans and we need it. We just don't need it when we're sitting down talking with them, having a cup of coffee. We need it in certain moments, but not every moment, which is what they currently are doing. They're currently using that in every moment of their, you know, lives right now.
How do you address forgiveness as a possible part of trauma work? This often seems to be a challenging topic with trauma work.
Yeah, so I think that's almost kind of a two-parter itself, because is that forgiveness, self-forgiveness, or is that forgiveness towards a perpetrator? And so I think it's kind of looking at that component of self-blame. Where is the self-blame coming from? Where is maybe that inner perfectionism coming from? And kind of exploring pieces like that. And the stereotypical, like, forgiveness doesn't mean forgetting. A perpetrator did what they did. We cannot change that they did that. And at the same time, by being in a space to move on from it, we're not saying it didn't happen. We're just saying this doesn't get to control my life and hinder me anymore. So that idea of kind of letting it go, we're recognizing it's still part of our story. Unfortunately, trauma will live with us forever, but it doesn't have to live with us and keep us tied down. It can live with us, and we continue to triumph and transcend.
Mhm. Yeah, I love looking at that as forgiveness of self and others in multiple sense. There's like
Yeah.
the direct perpetrator, and then there's passive perpetrators as
Yeah.
well. Even more complex, because you might very much love and feel very connected and safe with a parent, let's say, and then also feel intensely angry that that same parent didn't protect you from some type of trauma that was experienced.
Yeah, I mean, our attachment styles at their finest.
Exactly. I'm wondering, we have just a little bit of time left before we'll close up. Is there like a fascinating, and I don't mean to put you on the spot, so you can totally, but when you think about like sort of complex or really, from an educational experience, cases that you've worked with, is there like a case that you could obviously redact information, but that you could share a little bit about, and sort of how some of these like skills and interventions came to life?
Yeah, definitely. We actually just recently had a resident who was a military veteran, and in the military, part of their role was like JAG related. So they were doing lawyer-y things. So they were hearing cases and whatnot, and they happened to be assigned to more sexual assault cases. And so a lot of what they struggled with was that kind of vicarious trauma, as well as they were a female in the military and did unfortunately get assaulted themselves as well. But their big struggle was like, how do I work through and process my trauma when my trauma is because someone worked through their trauma with me? And so it was kind of this like, I don't want you to be where I'm at, so I'm just going to keep it to myself, because I'd rather go down burning, but at least not take anyone else with me. So it was really coming to a place of bringing that understanding to them, of recognizing like, you clearly did not get trained in how to absorb that vicarious trauma and how to work with it. Like, we spend years in school, we get clinical supervisions, we get trainings that like we're mandated to do in order to continue to be clinicians. And this resident had said to me, she got one 20-minute presentation, like 20 years into her service, on vicarious trauma, and that was it. And so it was kind of explaining like, it's not your fault as much as it is like you just weren't prepared in how to handle this. So not only how do we heal, because she still ultimately did have that vicarious trauma. So how do we heal the vicarious trauma? And how do we also get a better understanding so that she can talk to me and know that I'm not going home and doing all the maladaptive behavior she did, because I have that different kind of perspective on trauma work than she just ever did. And ultimately, she was here for quite a while because she had a lot to unpack. But now she's in our PHP program. She is successful, with her family life. She's not only connecting to more adaptive behaviors, but her communication style has increased. She's looking at her sense of purpose and meaningful life very differently, all because of using her sense of self connected to emotion regulation, no longer feeling helpless, things like that. And so that's one that sticks out to me, just because of kind of the intensity of, how we think of trauma, especially connected to the military, and where they were ultimately able to kind of come from this. And they did also struggle a lot with, they were a very outwardly funny, charismatic person. And they're like, that doesn't mean I'm not struggling. And so when someone calls me strong and especially thanks me for my service, I'm like, what are you talking about? And so that was interesting to kind of see them shift from like, I'm not strong, I'm fairly broken, to, well, there is something someone sees in me, like they're calling me strong for a reason. So that was kind of cool to witness.
Yeah, that's a really fascinating case example.
Mhm. Oh yeah, there's like layers to that one. I could go for another hour.
So many layers to that one. So many layers. Listen, thank you so much for your presentation. Hold on before I end. I was seeing one more quickly come in and I don't want to end.
Any more questions? I'm happy to answer.
Some traumas, like in utero traumas, are not conscious stories. When clients don't have a narrative, are there other approaches you use? That's another interesting one.
Yeah, so I kind of look at that. I mean, very similarly, there are going to be a lot of repressed memories that we may just never have that kind of complete, movie timeline too. And so it's really understanding, how can we heal without that narrative? Are we able to still not have a racing heart? Are we able to not self-harm, even if we don't have that picture flash in front of us? So maybe we can still heal the nightmares, even though we don't know what the pictures of the nightmares are. And that's why we look at the what and not the why. So kind of explaining that to those individuals, or even if we do think of some medical things that could come up, things like a TBI, there's going to be parts that we're not able to heal because medically and mental health are two different components, and we can still get the mental health piece into a space that is helping us kind of overcome and move forward. So I always look at it as like a progression, how am I moving forward versus being stuck, even if I don't have all the perfect answers.
Thank you. Thank you so much for the presentation. Thank you so much for the time. Thank you to the audience for the questions and the participation. We really appreciate it. And we look forward to hosting more roundtables so we can have these important conversations about complex clinical topics. Keep your eyes open for more emails and invitations to future roundtables. And thank you, Samantha.
Awesome. Thank you so much for having me.